Somebody walks in with a drooping eyelid. Most of us would be tempted to say it is myasthenia. Ptosis is a localizing problem, not a diagnosis. And missing the cause can mean missing an aneurysm or a malignancy. The eyelid deviation depends on two systems. Levator palpebrae superioris, innervated by the oculomotor nerve or the third cranial nerve, and the Muller's muscle, which is sympathetically innervated. So, ptosis can arise from neuromuscular junction abnormality, abnormalities like myasthenia gravis, cranial nerve third palsy like with motor deficit and parasympathetic involvement, or just sympathetic disruption as in Horner syndrome. Each has distinct anatomical pathways, distinct clinical implication and outcomes. Myasthenia gravis is the commonest cause of fluctuating ptosis and bilateral ptosis, but structural causes are often missed if pupil is not examined. In third nerve palsy, you have ptosis, down and out eye, and a dilated pupil or mydriasis. This suggests a compressive lesion, usually an aneurysm. Horner syndrome, you have mild ptosis with miosis with or without anhydrosis due to sympathetic pathway disruption. In myasthenia gravis, you have a variable ptosis that worsens with fatigue, but the pupil is usually normal. Pupil involving third nerve palsy is an emergency until proven otherwise. It has got a strong association with posterior communicating artery aneurysm. Horner syndrome, in Horner syndrome, the ptosis is usually mild. If ptosis is severe, it's a third nerve palsy and not Horner syndrome. Before ordering any test, do this. Look at the pupil always because it saves time, prevent misdiagnosis, identify life-threatening pathology. At the bedside, you can use the bedside fatigue test, sustained upgaze for 30 to 60 seconds. If the ptosis worsens, that suggests it's a myasthenia probably. In ptosis, the pupil is the diagnosis and lifesaver. Ignore it and you will miss the lesion most of the time.